Good evening, everyone. I wondered if you could have a seat. So welcome. It's nice to see so many people here. So for those of you who don't know me, I'm Margaret Steele, and I'm very proud to be the Dean of the Faculty of Medicine here at Memorial University of Newfoundland. And as you know, this is a very special year for the Faculty of Medicine. It's a 50th anniversary of our school. And so we've been engaging in a number of activities, and the public speaker series is one of those activities. So this is actually the fourth out of a series of 5. So it's really nice to see people here. We're also putting it online so other people can view it live. And I know some people, I believe some people from New Brunswick are very keen to, I'm seeing the nod, so they're online watching. So it's really my pleasure to welcome Dr. Dennis Furlong, who joins us from Dalhousie, New Brunswick. And Dr. Dennis Furlong is a proud graduate of Memorial University Faculty of Medicine. So great to have him here. He completed his degree here in 1976. And then the following year, he opened a rural family practice in Dalhousie and soon became involved in medical organizations. And he served as president of the New Brunswick College of Physicians and Surgeons and the New Brunswick Medical Society before being appointed to the Premier's Council on Health Strategy. And I guess at that time you got the bug of the politics and was elected to the New Brunswick Provincial Legislature in 1999. And he served 2 years as the Minister of Health and Wellness and Community Services, and then 2 years as Minister of Education. And he later returned to medical practice in 2003 until 2015. Dr. Furlong is an accomplished athlete. He not only has won gold at the Canadian Senior Games, but has also won a National Research Council grant to research and develop a ground contact monitoring device for Olympic race walking. In 2012, Dr. Furlong was presented with the National Sir Charles Tupper Award, recognizing physicians who demonstrate exemplary leadership, commitment, and dedication to the cause of advancing the policies, views, and goals of the Canadian Medical Association at the federal level. And that same year, he was also awarded the Queen's Jubilee Medal. In 2004, Dr. Furlong published a book titled Medicare Myths, 50 Myths We've Endured About the Canadian Healthcare System. And I believe he's going to talk about that today. Today's presentation is entitled Sustainability of the Canadian Healthcare System, and it really will be interesting to hear his perspective. He's also been interviewed a few times in the media today in Newfoundland, and so it's great to have somebody with such expertise and leadership to tell us about the healthcare system. So after Dr. Furlong's talk, there'll be opportunity to ask questions. So welcome, Dr. Furlong.
Thank you very much for your kind comments, Dr. Steele. I have a copy of the book that is dated now, but more real today than it was when I did it 12 years ago. The numbers are dated, changed a few things, but the book talks about what I'm going to talk about today. It got a little traction in Canada about 12 years ago, but it's hard to get traction in healthcare with regards to change. So I have a copy for the Dean, and I have a copy for the library. Thank you very much.
Thank you so much. That's terrific. I look forward to reading it. Yeah.
Thank you very much, Dr. Steele, for kind comments. And yes, I did go into politics, but it was a couple of weeks after I had been playing hockey without my helmet. It took me 4 years to get away from it, get back to it. On the way back from medicine, people asked me before I went down, they said, well, why are you going from medicine to politics? I used to say, well, I was playing hockey with my helmet. And on the way back, they'd ask me, oh, why are you leaving the cabinet to go back to practice medicine in Dalhousie? I said, well, because in medicine they say thank you. And then there would be a pregnant pause, and they'd say, well, what did they say in politics? And I said, well, the second word is the same, and the last letter in the first word is the same, but the connotation is quite different. So thank you very much for the invitation to be here. It's nostalgic for me because it's my hometown and university, and grew up here. I would like to say congratulations to all those people in the stream, so to speak, in the last 50 years for the production of New Brunswick, Newfoundland Medical School. When I graduated here, there was no medical school, so the chances of getting in Dalhousie were a little short of impossible. And so I went in education for about 10 years, and then when the school started here in St. John's, I set my goals on it and was admitted in 1972. I want to start now because it's a long topic. Healthcare in Canada is large. It's our biggest expenditure. It's our most treasured program, health program. It is now under some duress, and I think we should be making some moves, and I will get through them shortly. As Zakaria says every Sunday afternoon with CNN, let's get started. And that's what I'm going to do. Fasten your seatbelts, and we'll see if we can get through a bit of this information. I have to go through a whole bunch of things to give you the perspective of what is happening now. You need to know a bit of history, what has taken place, how it's taken place, and the general structure of Canadian healthcare to appreciate why we have some impending difficulties that are coming at us. I want to say that when I finished here in actually 76 graduation, 77 rotating internship, which was unique now, but it was the usual in those days. I left here the last day of the Canada Games and went to New Brunswick. And it apprehension, of course, in all students, I presume there's students over here, but apprehension facing the world of medicine from school, and I had that, of course, they all do. But 6 or 8 months in, I realized in a general hospital where we were always alone, about a 100-bed hospital, 25,000 people, full service, pediatrics, obstetrics, emerge with everything that could come in and emerge, and general surgery, as I mentioned, and a concentrated care unit, and quite a daunting start. And 6 months in, I realized that Memorial had trained me very well. And it was clear that I was able to do the things that the population were going to expect of me as a trained physician in Canada. So for that, I thank Memorial and its excellent care. I think Memorial had about 3,000 graduates over those periods of time empirically. All of them will probably work 40 years. If you add that up, you got about 240, maybe 120,000 physician years of service for Canada, Newfoundland and Labrador, and somewhere other places around the world. I will talk today about the main theme, which is transformative change in healthcare, which is needed now because there's been none, basically, over the whole 40 years of Medicare. We basically are operating in the same way. There have been changes in the, of course, the clinical and scientific component, but the structure of delivery hasn't really changed and seems to be dysfunctioning over the last 10 to 15 years. I also want to start by saying Canada is tops in the world as a country. We have 3 oceans. We have an inland ocean. We have an inland waterway that goes halfway around, across the continent. We have peace. We have order. We had good governance, no matter what color the government. And the big, point that's so important is that if we don't like our government, we're able to get rid of them. And that's not true in many, many countries around the world. So Canada is a great place to be and to live. if we look at healthcare, as I said, it's our biggest expenditure, $230 billion a year, and rising. And we're in a public-private situation when we call it 230 billion, 11% of GDP, and that's consistent with most of the OECD countries, 30 or 40 countries that have public single-payer systems. All of those other countries are around 11%, but they include pharmacare. We don't have pharmacare, and that right now costs more than all the doctors in Canada. So you can see that we are probably spending a little more money based on just not having pharmacare in our public program. And we should have. The pharmacare was first talked about in Canada in the 40s, during the war, right after the war. And we've been bandying it around ever since, and we've never been able to come up with any kind of agreement to be able to do it. And we need to, because we have probably some of the most expensive prescription drugs in the world, and we could do something very, very intuitive and probably reduce those costs by, I guess, looking at what's going on in I think New Zealand. We could be reducing those costs by virtually half. So there it is. Issue with pharmacare. We will move on, and I want to make sure that we understand that any comparatives in the OECD countries, the Americans are an OECD country, the comparatives fail when you try to compare with the United States. Their system is totally incongruous with everybody else, and I think even Stephen Hawking couldn't figure it out these days what's going on down there, with an IQ of 180, and so we can't use the comparatives with the states, although they like to use comparatives, and their politics, they say, when they're into their issues of healthcare, they will say, well, you can't do it like Canada up there. Look, everybody waits forever up there, and that's socialism. Communism. Socialism. Communism. Oh, that kind of attitude is what they're dealing with down there, and it's unfortunate because the people are suffering. I want to also say that the quality of providers in Canada are some of the best in the world. The allied health professionals, LPNs, nurses, nurse practitioners, doctors, physiotherapists, respiratory therapists, cardiac cardiologists. We are tops of the world in our training, and the Americans will take everybody that's trained in Canada tomorrow. Matter of fact, right now they're looking for 80,000 doctors in the United States, and there's 80,000 doctors in Canada. They're not going to get them all, of course, but they'll be looking up here as they always have. The biggest difference that I have seen from one program, from basically zero to top of the line, believe it or not, is pre-hospital care. When I graduated, an ambulance was a truck, two drivers with a white coat from what we called at that time the St. John Ambulance, and that was it. And if they had a license to drive, that was what we had generally throughout Canada. And today we have pre-hospital care that's leading the world. And when there's an injury or an episode, healthcare starts when they arrive, and that's phenomenal. When we were doing ambulance services in New Brunswick back about 25 years ago, I think it was $3 million, and now it's over $100 million, and it's well worth it. And you might say, well, what can you offer us tonight on suggestions here? Well, what I can offer you is perspective. 40 years in the system, a lot of local, provincial medical politics, some national medical politics, Medical Council of Canada, and of course the sojourn I had in the Department of Health and Education. And even when I was in education, the cabinet table was dealing with health issues, and I was able to effect some changes and appropriate things, not not only affect some positive changes for things to do, but interrupted some things that should not have happened, and they didn't happen because I was able to speak. I want you to keep an open mind on what I suggest tonight, as change is resisted by everybody in society generally, and no doubt anything that is disruptive is change, and change is disruptive. The change that I'm suggesting, I did 10 years ago, as I said in my book, and again, it will be resisted by people, but I must ask you to be patient with change. People don't respond to it. Change is glacial usually, but better than tsunami, because you can't control a tsunami, but you can sometimes control slow change. The only change that people universally accept immediately is a diaper change. Well, you can be sure of that. Options for transformative change I will suggest, and the perspective of 40 years in the system is real, and I've been able to see a lot and understand a lot. When I first started in Dalhousie, I did obstetrics. Matter of fact, one of my deliveries is here in the room tonight. When a lady would come in then with a first pregnancy, with big eyes and smile as wide as a house, and excited and going to have a new child, they had many, many questions. And usually one of the questions was, "Doctor, when will the baby move?" And I would launch into this, 17 weeks, you'll feel a little flutter, and then maybe 18 weeks, a bit more of a kick, and a little time later, baby will wake you up, and later it'll wake your partner up. And after a family and 3 boys, and last 4 or 5 years ago when I finished obstetrics, same thing. The ladies were coming. This time the spouse was there, and they were usually there before. And the same questions came up, this, that, and the other thing. And inevitably I was asked, "Well, when will the baby move?" And being in my 60s, I said, "Hopefully after graduation." I am not a healthcare economist. I'm a rural general practitioner. I want to clarify that right away. My numbers here tonight are soft. They're not hard like the people who earn their living with healthcare economy. I will say that they also will reflect very well the nature of what I'm going to try to portray to you tonight on sustainability in healthcare in Canada. And the first slide is about sustainability. And you might say, "Well, what's sustainability? What does it mean? What's it all about? Does it mean things will stop all of a sudden one day, or what?" I will leave you to decide tonight after this whether you feel sustainability is viable or not viable, or if the changes will be fiscal, or if the changes will be quality of care that we can deliver with overwhelming resources coming, or requests coming at us. So what can be done with regards to sustainability? The question I've had, and it was more realistic in the last month or so, was who will lead the change that are necessary for healthcare in Canada? Right now, as you will hear a little while later, the federal government appears to be getting out. I'll talk about that a little bit later. The sustainability is, let me see if I can get this thing going. Sustainability is all about affordability for all provinces, and affordability is all about utilization, and we'll talk about utilization because it's a big issue. And utilization is all about accountability, and we have none in our system now, none, on either of the 3 parts of the triangle of care: the consumers, the providers, and of course the insurers, the governments of Canada. And most OECD countries, almost all except 3 or 4 or 5, have accountability measures on the demand side. We have never done anything on the demand side in the 60 years or so of public health care in Canada, and it's needed now. And it'll become more clear why I say that. I said all three sides have not done anything on accountability. Well, that's not quite true, because the providers of Canada, the Canadian Medical Association, has led a little parade over the last several years about what we call choosing wisely. Okay, that's an effort on the part of the doctors that is a testament to overutilization, and I think it's far, far bigger than what choosing wisely can deal with. I estimate that choosing wisely will not get much traction. Number one, it hasn't been incentivized, and number two, it's based on idealism, and it's all on one side of the equation, and doesn't in any way reflect that the consumer is the driver of utilization, not the providers, as governments would like to say. So choosing wisely brought us to what we have. Let me do a little bit of history as I go through as well. 50 years ago in Canada, there was about 24 million people. There were about 29,000, 30,000 doctors. 90% of those doctors were male. 80% of those doctors were general practitioners, and 20% were specialty, about that. And there was one MD in Canada at that time for about every 900 people, and the population seemed to be served for some way. The cost at that time was about 7 or 8% of GDP, and prior to Medicare, it was 6% of GDP for public or for healthcare in Canada. Today, we have 36 million Canadians. We have 88,000 doctors approximately. 50% of them are specialty people, and 50% are now primary care. And about one MD for every 450 people in Canada, quite a change. And there's an enlarging gender shift, as you're all aware, which is very healthy and welcome. 11% of GDP today, still, as I mentioned earlier, and 40% of provincial territorial spending, which is rising quite rapidly. We got to the point where Medicare was born in Saskatchewan, and some of you may know this story, but some of you may not be old enough to know it. Tommy Douglas was the one, as Premier of Saskatchewan, and the NDP government said that he wanted to cover hospital services, and that's exactly what they did, and it went push one end of the country to the other all of a sudden. And then they rapidly realized they need to cover physician costs too, because it was inhibiting people going to get service. So very rapidly, the second program was put in place, physician cost, and it went boom right across the country as well. Doctors could still extra bill if they wanted, I think up to 10% or something like that. Very few, if any, did that. And the Tommy Douglas then made Canadians very happy, and inevitably when they had their program of who was the greatest Canadian, there was no doubt in my mind it was going to be Tommy Douglas, and it was him, because people treasure their public health care system. That's part of the reason why I'm here today, and why I've been lobbying actively for about 15 years for transformative change in what we're doing, so that our great-great-grandchildren can enjoy the same things that we have in public health care. I'm not sure about it. This is Tommy Douglas at the microphone back sometime in the 60s probably, and he was the driving force and the greatest Canadian. I organized myself here. Everybody was extremely happy, and even these guys, okay? Everybody who's vintage like me, they said, I'm happy to be here tonight, but I'm happy to be anywhere tonight with my vintage. But Bob and Doug McKenzie were happy, and Canada, eh? I'm having a beer, eh? And everybody remembers them. They even got traction in the United States. And this to say that everybody was elated with this, the program. And the federal government came in with the provinces and 2 territories at that time, 50-50 on the dollar. And the provinces were uniquely elated because they could build a hospital for half cost, they could hire a doctor for half cost, train a nurse, buy equipment, all the things that we didn't have, we could do for half cost. So it was good times, and the federal government was in for 50% of the spending. The Canada Health Act came next. That was some years later, quarterbacked by Monique Béguin, Federal Minister of Health, and Justice Emmett Hall, who did the spade work to put together the Act. And the Act is, as you see it right in front of you. And they eliminated extra billing, in effect making it illegal to charge for health care. And there's Crowley was that you couldn't buy it, but you also couldn't sell it. So we're dealing with issues today about selling it correctly. You know, we see today that the charge is there for the Canada Health Act with regards to the way we're operating today. If you do look at those 5 basic principles, you'll see a check and a check, because the two, universality and portability, are still as good as they were day one. Very simple. Universality means if you're Canadian, you're covered. And now impending Canadians are covered. And the portability means that if you're Canadian from Newfoundland, you're covered in Alberta or anywhere else, and it's reconciled later. So, but comprehensiveness is pretty much the same. There have been some changes, but nothing dramatic. But I say that comprehensiveness, I put a plus and a minus there because it's compromised by the big one, accessibility. And accessibility now is dangerously poor in Canada, with wait times that are anywhere that can be up to a year or 2 years, and sometimes 2 years to never. And I've seen that myself in my practice, and it's very, very difficult to get service. And for a whole variety of reasons that we'll try to talk about. Publicly funded has been hammered to oblivion by the country, most notably the Supreme Court in Quebec in the Shaoli case, and now an impending case with the former president of the Canadian Medical Association in BC, and we're going to lose that one as well. And publicly funded now has been lost almost completely. And accessibility, boy, emergency rooms, wait times for consultation, even now 3 months wait time in many places in Canada for primary care, worries me a lot. So this led us to the Canada Health Act, and again, like I said, illegal to sell health care and therefore illegal to buy it, and we're living with that problem today. In Saskatchewan, the physicians went on strike because they didn't like the idea of this intrusion into medical care in the country. That was traditional domain of physicians. But they had not a hope because everybody wanted this, every person wanted it. And not only that, the government said to the people, why are they striking? All we want to do is pay their bills. And so they went back to work right away, and things have moved on to what we have today. Next concept I want to put across as a theme, again, is useless utilization. What does it mean? What does it cost? How much does it cost? And what is this about? Well, I empirically believe that about 20% of what we do in the country in healthcare is functionally useless and doesn't do anything for anybody's health and costs a considerable amount of money. We'll talk about that a little bit more. About 4 or 5 years ago, I was in a conference in Toronto, and next to me was a healthcare economist, MD guy from El Paso, Texas. He presented, I presented, and we had questions. And I asked the first question to him, and I said, well, I feel that 20% of what we do in Canada is useless utilization, overutilization, misutilization, duplication, all those things that add up to a number. empirical as it is, I still think it's around 20%. And I asked him, I said, what do you think it is in the United States? Well, we know, we've done the studies. I said, would you enlighten us? He said, well, it's 35%. 35%. On a $3 trillion budget, that is, guess what, $1 trillion a year that they are functionally wasting in the American system. But here I think it's about 20%, and we can do something about it, and I'll try to explain that as we go on. So useless utilization is real. And I think any practitioner that spent the time like I have over 4 decades, you can't say it's this, it's that, it's that. But overutilization is a generalization. But I think that if there were some accountability measures on the demand side, about 20% of the utilization would go away. In New Brunswick, ironically, we had hospital services where government said, oh, we're going to charge $100 for a hospital service to a residence to pick somebody up or whatever. And immediately the reduction would be about 20% in utilization. Then another government would say, well, we're going to put it back in, vote for us. So we come back, put it back in, utilization goes up 20% again, and it beanbagged up and down 4 or 5 times over 10 or 15 years, giving the indication that, of course, when there's something to pay, there's less utilization, and that's a fair assessment. The Canadian healthcare system is a misnomer, okay? And I've said this on occasion, and I'm not sure if I didn't start the trend of calling it a misnomer. It's not really a Canadian healthcare system. It's a conglomeration of 13 now, originally 12, provincial, territorial illness care systems that have a component of about 8% or so of public health and so on and so forth. But none of them are the same, yet they all are similar. They all spend different money. They all have different rules and regulations. And there is not much unanimity between the provinces and territories. They meet, but we share more science than we share operational stuff. So it is an issue, and when we call it the Canadian healthcare system, it's part of the reason is we can't get any traction on pharmacare, is that we can't get much traction on cooperation actually in our confederation. It's a kind of a pseudo system. We hear it called the Canadian healthcare system, but if you really analyze it, it is not. And we'll start with theme number 3, which is accountability. What does that mean? What are the implications? What are the things that are associated with accountability in the system of Canadian healthcare? As I said, most of the OECD countries, except maybe 4 or 5, I believe, have accountability measures on the demand side. Okay. And we have done everything on the supply side since the inception of Medicare, and never touched the demand side. That is to put accountability in the system, and we don't have any now. Selectively, it should be done with insurance principles. Insurance principles are pretty simple and not too many of them. And if you look at OHIP, OHIP, well, Ontario Health Insurance Plan. Well, there's no insurance principles in there at all, even though it's called an insurance, and there should be. And the 3 insurance principles that we have are basically the premiums that are being applied now right across the country. And the first one was Premier McGuinty in Ontario, and they very rapidly started calling him Premium McGuinty, and that's there. BC recently has just added $75 a month for people to keep their Medicare card active. They're not telling them that this is for costs of healthcare to keep your Medicare active. If you don't pay your $25, presumably it falls fallow until you pay. And I only heard that about a week ago from a doctor who was visiting me from BC, and I said, "You got to be kidding." Yep, that's true. And also, um, they have now said to the primary care people, apparently, and I want to confirm this yet, that they're limited to 40 patients a day. Good luck. The 41st one might be the one clutching his chest, sweating a lot, and and having a major event. If we're going to look at substantive change, then who will do the leadership? The federal government is not in the game anymore and are getting out, and I'll explain that a little bit as we go on. They continue to make hot potatoes like healthcare, and 15 of them fire them out to the provinces who have to juggle for a while until it cools off. That's what's happened with healthcare over a longer period of time. And the same thing has just happened with cannabis file. They made all the rules and everything else and threw it all out to the provinces who are not ready. And the provinces have to live with it and deal with it and pay for it and so on and so forth. So in healthcare, who will lead the parade for restructuring or any kind of reflection on how we're delivering it? About 2 months ago, Bill Morneau came to Moncton about the issue that's pervading the country right now. And I had a moment to catch him face to face in the corridor. And I asked him straight ahead, is there any appetite in Ottawa for transformative change, some initiative on the demand side of healthcare? And never took him like a second. He said, not our problem, not our problem. It's your problem. Turned and walked away. Oh, the feds, it's federal legislation after all. And it is the federal government, and he is in the cabinet. So if the feds, that's made me convinced that the federal government is getting out of healthcare, and I'll add more information to that in a minute. If not the federal government, then the only other agency I can think of is the Canadian Medical Association. That's universal across the country, that has some import and some, but I'm not sure they would want to get into that. And if that doesn't happen, then I'm quite convinced that as things get difficult over the next 20 years with the impending silver tsunami that I'll talk about a little bit later, then it's going to be the people of Canada who will rebel and say, hey, whoa, I'm waiting 3-4 months for a general practice appointment, 2 years for this and whatnot. Then it'll come from the bottom up. If it can't come from the top down, it'll come from the bottom up, and I will predict that now tonight. The next theme I have is insurance principles. I talked about it briefly, and premiums, co-pays, or user fees, number 2, and number 3, deductibles, which is what I'm suggesting, a deductible that would be applied. And there has to be some very firm provisos. If we do go that route, it's what I said in my book 12 years ago, it will be the first time that we do anything on the demand side. It would be prorated. It would be a tax-based model so that there's no money seen in the system, and that's one of the initial provisos. No barrier to access that's based on money or cards or checks or anything. None. We've tried that with user fees back about 30 years ago, and you're hardly likely to be running down the corridor with your 4-year-old with an asthma attack and looking for $5 to get in the door. Not going to happen. It didn't happen, and governments very rapidly figured out that putting in the user fees way back, it cost $10 to collect 5. So the deductibility is prorated patient participation, that I call it. Roy Romano, in his report, polled the country, and about 70% of people polled said we would gladly pay 10% more to keep the healthcare system in good shape and available to all. So the people already spoke. Also, Bill Morneau and Fred Vitesse wrote a book 2 years before he went to college. It's called Real Retirement. It might be worth reading because some fairly good stuff in there, but in his healthcare part, he suggested that he alluded to the fact that we should be looking at some form of demand side controls. So, Federal Minister of Finance thinks it's not so bad, and maybe I wasn't off the mark so much 12 years ago. Janice McKinnon, former Minister of Finance in Saskatchewan, who I think now is with the University of Saskatchewan and a PhD author and so on and so forth. We did a conference at Queen's in Kingston, the School of Public Policy, and we were both speaking, and she made it very clear that she thought that we needed to do something on the demand side. The Canadian Health Policy Institute only last month or before suggested some demand side initiative. And it's out there. I've heard almost every premier in Canada say it's not sustainable. Almost every health minister say it's not sustainable. The joke in New Brunswick was that before long we'll have two departments in government, health and finance. And with growth, that's going. But of course, that's not going to happen. But the former Attorney General, not Attorney General, Sheila Fraser, well, before she finished, said that we were not getting the bang for our buck in healthcare in Canada, and I believe she's right. Built into a program like this, you would have an incentive to not use the program, and in the same way, a disincentive to use it. And that would hopefully do something with the overutilization factor, which I said is somewhere in the vicinity of 20%, 45 billion a year, and about half a billion here in Newfoundland every year, and half a billion in Ontario. So, I will move to another slide. The first thing we're going to hear when we talk about this health care, I guess it would be called heresy that I'm suggesting here tonight. And I even, St. Thomas University did an interview with me one time and put it in an article that they put out quarterly, and it came out on an afternoon, and the next morning the Minister of Health in New Brunswick said, it's nothing but user fees. And so did the opposition health critic said, nothing but user fees. They didn't even read it. So getting traction is going to be difficult at that level. However, we may have to suffer more pain before we can solve the problems. What do we got here? This is the federal government approach to healthcare back with the last accord, and that's exactly what we get. Now, in the past, do a little bit more history. In the past, before Medicare, we were at 6% of GDP, I mentioned, and we generally at that time took care of disease that was existing or disease that happened to happen in society, and people went to doctors, and trauma, obviously. And most of what we did when Medicare started was reparative to an issue. And a small percentage of the population actually used the system at the time, believe it or not, back 40 years ago. Prior to Medicare, physicians had about 50% accounts receivable, and 50% of their work was done gratis. When healthcare became public with 100% accounts receivable, no questions asked, within 2 weeks, most people on the provider side were also very happy. At that time, governance in healthcare was local. In New Brunswick, there was 34 boards of health. Okay, now there are 2. And there would be one if we didn't have the issue of satisfying both entities in our province, which I believe in and will continue. So governments in their own way had to get control. So 14 or 34 boards, all yelling and yapping and so on and so forth at government all the time. They go, well, let's get so down to 2 boards, so they only have to deal with in New Brunswick 2. But in Alberta, interesting thing happened with 4 million people. They made 1 super board for the whole province, and people had concerns about it. The providers had concerns about it. They hired a fellow by the name of Stephen Duckett from Australia to come and be the chairman of that board. About $20 billion worth of spending. He had a meeting one day, and he came out of his meeting and was walking up the street, and there was 4 or 5 press with the microphones in his face, and by and by, he wasn't answering, but by and by he said to the press, "Can't you see I'm eating my cookie?" And the Cookie Monster arrived the next morning, and he got a plane ride back to Australia. So that was a paramount problem that you have to deal with, issues with press and people's concern about our most treasured program. In Newfoundland, we had the cottage hospital system to a degree, and it was born out of the British system of what we lived with here for many, many years, and it worked very, very well. People were enticed to go to the cottage hospitals by having support for their training programs, and then they would commit 2 years and so on and so forth. A little different, but in general, in those days, there were boards. Everywhere there's a community, there was a health board. And now, of course, we're down to a much better way of delivering and standardizing how we deliver care. In those days, healthcare was very much vocational and missionary in mindset, and now it's more mercenary, and we have gotten into conflict with government as a profession, with our professional associations, and that conflict is up again, off again, down again, back again, so on and so forth. But physicians are moving out of the, I guess, effective advisory roles in healthcare generally across the country, and we now have a large cadre of people who are non-clinical background who run healthcare in Canada. I'm not saying it's bad or good, I'm just saying that the physicians have now been basically not part of the discussion. Matter of fact, if you look back and you watch it, the governments of Canada have blamed the incremental costs in healthcare on the providers. I'll give you some examples of that shortly. The current issues going on between the federal government and the Physicians of Canada and other structures in Canada is not very healthy either, and I think it'll probably push a lot more physicians into salaried positions as they abrogate a little bit with regards to fee-for-service and so on and so forth. So I wait to see what the effects of this will be. Theme number 6 is costs. Where are the costs? How are they spent in our system, and who's spending them, and so on and so forth. Again, for a little review, $230 billion a year in Canada, and we have had times when the incremental costs of healthcare at 5, 6, 7, 8% per year, the growth of healthcare in Canada was over $1 billion a month, and sometimes a little more than that. The last 8 years, we've been somewhat less because of the recession in 2008. About 80% of healthcare is a salary for somebody, and when salaries don't go up, healthcare costs stay much the same. We've had politicians push their chests out and say, "Look at me, I controlled healthcare and got it down to 2%. There was nothing to do with it at all, except for the recession." So these costs and growths were real. Governments were reeling under the pressure of these incremental costs. And in governments, healthcare was almost for 20 years, it was the spending that was determining the budget. and not the budget that was determining spending in government. So we had growths that were quite large, and again, on 40% of the budget, it's a lot. When your growth rate, your provincial growth is 2% and 40% of your budget is growing by 8 or 9%, that's clearly fiscally unsustainable. Let me see this one. Provincial debts. I'll talk a little bit about provincial debt before we move on a little bit further. It would be probably wise to just say Newfoundland and New Brunswick are about the same, and most of Atlantic Canada are about the same. In New Brunswick, we owe about 14 billion, and here it's about 15. We haven't been able to balance the budget for 13 years. Matter of fact, the last balanced budget we had in New Brunswick, I was at the table, and I was adamant about it, and always yapping about not spending our grandchildren's money. But since the last 13 years, we've gone from 4 billion to 14. And if we were able to find the 500 million to balance our budget in New Brunswick, which we haven't been able to do for 13 years, and then somehow found another 100 million to put on the principal of the debt, it would take us 140 years to pay it. And that's not including interest. If you add interest, it might be 2 centuries. And somewhere in this whole equation, somebody has to say, hey, whoa, do you think we might have a problem? And that exists here in Newfoundland, that exists in a number of provinces. So we're into good times, the recession is almost over, and provinces are still borrowing and spending and not paying attention to the debt. This one, it starts up above. One day, all of this will be yours, saying to the kids. And you know what? The young people of Canada know this. And it's discouraging for them. And we really should be doing something. And one thing we can do is try to control the biggest program and make it still effective, but make it more fundable. As soon as you talk about public health care and patient participation in the cost, then immediately you're going to hear somebody saying, well, whoa, you know, what are the poor old people going to do? If you look at this as Bill Morneau's document from Real Retirement, I thought it was apropos to look at where we stand with regards to our seniors in Canada. And we're not too bad. If you look up there, you'll see at the top, U.S. Poverty rates of seniors, 24, 22 in Japan, 17. Look at Canada. Not too bad. And if you look at the general population, this one here, same kind of thing, US 24, general population 17. You come down to Canada, 12% in general population considered in poverty and 5% in our seniors. So we have to understand that the baby boomers made lots of money and are the richest cohort of Canadians that ever existed and probably ever will exist. And right now, the baby boomers, of course, started in 45 to 65, and the first thin edge of the wedge is starting right now at age 70, just this year. And when they were delivered, there was a big run on diapers. Okay. A little while later, a big run on carriages, prams, then tricycles, and then bicycles, and then motorcycles, and then sports cars, and then getting married. And now they're entering their senior years, and the last crowd to let you down are the funeral home industry, and they're salivating right now because they're all coming. And the federal government are equally salivating because they're setting the stage right now for succession, okay? As the money from the baby boomers transfers to their progeny, they're going to grab a very large percentage. And from what I'm looking at, it might be half And that goes for corporate structures and individual. So we'll see what happens, but that's what I see that they're doing. Now, when you look at spending, I talked about it a few moments ago. This is the hockey stick slide, and it's worth looking at. It's probably the most important slide tonight. There's a bit of humor in those slides, but this one is very real, and it shows you why we have a problem right now. We have what's different now and over the next 20 years than what it was for the last 20 years. We've had growth in the last 20 years that's very, very tough to deal with, and we've stole money from education, stole money from transportation. If you hit a pothole, it's probably healthcare. If your road is not paved, it's probably healthcare. Right across this country, and especially in the poorer province. But if you look at this, you'll see the first year of life, first 12 months, about $11,000 per capita. And I remind you that the average per capita in Canada is about $6,000, somewhere around there. And look what happens in the second year of life. It's about $2,000, maybe $3,000, and it keeps going at that. And right here at 25 slips up a little bit. That may be related to pregnancy, I don't know, but anyway, it slips up a little bit. And when you get to age 50, it's right here at about, again, $3,000 or $4,000. At age 60, you're still not $5,000. And if you come to this age, 65 to 69, it's up to about $7,000 or $8,000 or whatever. And you can see what happens at age 70 to 74. It is still not over 10,000. Yes, it's over 10,000, about 12. 75 to 79, you're looking at about 13 or 14. If you go to this one here, 80 to 84, you're looking at $16,000 or $17,000 a year per capita, I remind you, per capita. And look what happens here at 55, or 85 to 89. And age 90, it's costing pretty close to $30,000 a year per capita for care. And this has always been there. The change is that the number of people in this segment right now is going to triple in the next 20 years. That's why we're going to have problems. That's why I'm saying we need to do something now. So you'll see that that slide is very relevant to the theme today, which is prorated patient participation. I'll be quick and try to get to questions very soon. I'd like to talk about rationing. We in healthcare have always talked about the issue of triaging patients, and inevitably everybody did it. Even sometimes the guy who was cleaning the floor saw someone that was staggering in the corridor and said, oh, gee, this guy needs to be seen right away, and go right to the front of the line. Triage has been a real deal in Canadian healthcare forever, and we were able to get the sickest in the fastest, and that's what we always did. That is failing now a little bit. And we're actually rationing healthcare. As I said, frighteningly, BC now said you can only see 40 patients a day. Well, gee, I remember days in rural New Brunswick when it was 80 to 100, and you start at 7 in the morning, finish at 11 at night, not every day, but if I had to stop at 40, there would be a lot of people on service. And I never called anybody in my office, ever. We took care of 5 or 10 patients every day that didn't come to the office and didn't pay anything, and that was the way it worked. So it's changed. But top-down austerity, governments, the only methods governments have been able to use when costs started to go up has been top-down austerity. And what do I mean by that? Well, the only way they could cope with it, because they didn't have the knowledge of the system, was to restrict supply and try to control demand. And the more they did that over the last 20 years, the more the wait times went out. And now they're out to 2 years plus, and sometimes never. Back in the 80s, there was the Berer-Stoddard report. Anybody remember that? Anybody heard of that? Well, that was a feeble attempt by the federal government where they blamed the providers for the increased costs in the system. In other words, the doctors were driving the increased utilization. And nothing could have been further from the truth. So Berer-Stoddard were hired by the government, 2 guys, And they were obviously coached, and what are we going to do to control health costs? Well, the recommendations to the federal government that leaked early was to close 2 medical schools. And I believe they mentioned Sherbrooke and McMaster. Well, the expletives are still rolling through the country in both French and English. It was just a poorly thought out, irrational, uninformed way to deal with the problem. So they went back to the drawing board and came up with an equally stupid solution. Instead of closing 2 medical schools, we'll close 10% of all the entries going into all medical schools. And it took us about 2 decades to get over it. 2 decades, because they interfered with the supply, hoping that the demand would go away, and of course it didn't. That's the mindset of governments: reduce supply, control the number of beds, number of doctors, number of nurses, number of boards, and hope that the demand goes away. And still never once thinking that maybe they should do an initiative on the demand side, which is what I'm recommending. Service delayed now is service denied, and we have some difficulties right across the country in that light. The boomers are here to stay. They're now a group that are entering the system, and they're all going to be over in that part of the hockey stick, and very costly. And we could see that component of healthcare triple in cost. And we're not considering all the new things that are coming, which I'll mention shortly about where we are in the science of medicine. The boomers are very discerning people. They're well educated in general. They're demanding. They're entitled, and they feel entitled. They're more litigious now than ever, and this is not going to be fun over the next 20, 25 years if what I see coming is becoming difficult in the daily operations of healthcare. We have some glaring problems with regards to supply of human resources. In Canada, we have 1 rheumatologist for every 100,000 people, almost impossible to get in. 2 or 3 years ago, there were 7 in New Brunswick, I believe, and not one was taking new patients, whatever that meant. We have issues with neurology. It can be a year or 2 to get in. Orthopedics, gastroenterology, long waits. The other question is that we have now, we're graduating, I guess, or training some of the cutting specialties that are having difficulty to find work in Canada because it's hospital-based and they've got hospitals controlled and a little difficult to get in. So those are things that we have to work on. What will be the controls that we will see over the next 20 or 30 years with the demographics, with the feds getting out? They are clearly now restricted their money to 3% as a minimum in the future, and they've restricted growth to the growth of the economy, which is about 3 or 4%. And the healthcare economists are telling that we're never going to see those growths as we have seen since the Second World War I mentioned earlier. The provincial debt loads we've talked about, and those are ominous. Rationing we talked about, and it's a real issue. And it'll have to be, well, one wonders who's going to do the rationing. Well, we have this thing in BC where they say you can only see 40 a day. I am quite convinced that governments will coerce the medical profession into doing the rationing. This right here, some of you may look at that and say, well, what's that? Well, it's Petawawa. What's in Petawawa? Military. They're all in their 20s and 30s. They have lots of kids. That is a portable classroom. Portable classroom, this part right here. Because they got so many kids, they couldn't deal with them, they built portable classrooms, which is what we did for the baby boomers way back to get them through. Now we got to get them through the healthcare system in the next 20 years. The politics of healthcare, I will just say that it'll always be a political football. There's no question about it. You can't do healthcare in Canada without the politics. Governments are continuing to avoid making the tough decisions, and we got rotational governments now. A lot of governments last 4 years and they're gone, and the attitude is, why rock the boat? We'll leave it for the next crowd and then complain about them. So we're not getting tough decisions made. And as long as, I said this to the Senate about 3 months ago, I presented to the Senate and Senate Finance Committee, and I said, as long as getting elected and staying elected, and I hate to say this word in here, as long as getting elected and staying elected trumps fiscal sanity, then we're never going to get this problem solved. And it appears that that's the way we're going. I'm almost to the last bit there, and then we'll take some questions. I hope nobody is going to fall asleep. And if any of you didn't have supper, it's probably your hypoglycemia that's keeping you awake, not hyper. The art and science of medicine, we need to talk. I always said that I would quit medicine if we didn't have Pitocin, Lasix, and Ventolin. But today, when I started medicine, we had about 40 drugs you could survive with, and you had to know them all, and you had to know the interactions. Now there's 10,000. Chemical therapeutics have gone like this. They're immensely more effective and targeted and efficacious than when I graduated. Imaging, I don't need to tell you how dramatic it is now with MRI and CT and so on and so forth. Invasive techniques with scopes on the investigative and the therapeutic side, it's phenomenal what's being done. Standardization of specific standardization of disease management has been hugely effective with, again, asthma and congestive heart disease and so on and so forth. Standardization that's come right across the country has been very effective. Laboratory science, now you can measure a serum rhubarb. You can measure anything in the lab just about today. Incredible. Genomics, personalized therapy, immunotherapy, advancing now into cancer therapy, liquid biopsy, CRISPR genome editing, which is really exciting and happening in China and other places. So the new world of medicine that's coming for the young people who are training right now is absolutely astoundingly wonderful. And of course, then along with that, above and beyond the numbers that we have for 20, 25 years with this bump in the road with the baby boomers, there are going to be more increased demands, more increased costs, and service demands with people who see all these wonderful things happening. Issues to do with dying were started, and I think that medical assistance in dying is probably appropriate, and if done properly can be effective for the client who wants that, or the patient who wants that. The opioid problem now, I'm not sure where that's going, but it appears that we're going to end up with a specialty that's coming out right now in opioid control and management. Also, litigation is starting to be big and more prominent in Canada, especially in the bigger provinces. The continued and ever-present difficulty for doctors to know where in the continuum of illness you get to the point where you're preserving life or prolonging life to the point where you're prolonging death. And that's a really tough thing that all of us have wrestled with forever in our careers and becoming more of a challenge. Again, now I'll finish up by saying prorated patient participation, an issue on the demand side. No proviso that there be no barrier to access, that's financial. No exposure to catastrophic costs of any sort. That there be exceptionality, which may be things like immunization, prenatal care, natal care, postnatal care, or selective congenital things like cystic fibrosis or whatever, has to be worked out. We would have to have the actuarial work done. We would have to have smart cards instead of the Medicare cards that we have right now. And I think that the only answer is to go prorated patient participation. Governments are all adding now to the supply side with a variety of premiums approaches, and they drive utilization. People say, well, I paid my premium, I'm going to use it. But with a deductibility, it becomes like your windshield in your car. If you didn't have a deductibility on that, the insurance people are not crazy. If you didn't have a deductibility, they'd have 50 times more windows broken and replaced for free on covering the first dollar. So deductibility is the way we should go, and I think we need to go that way because I think the health system now is in a bit of peril. I don't believe for a minute it'll collapse any day. I do believe for a minute that the quality of care that we can do may not reach the people because of overutilization and inspisation and the problems we're seeing in our hospitals now, both with the inflow tract in the emergency rooms, which is basically a product of primary care, and the outflow tract, which is a product of our seniors, where we have now 30% of the beds in Canada that are effectively not available to the sick people, but the people who are chronically ill who basically have no place to go. And with the beds in Canada, 20% to 30% of bed, governments love it. They're called bed blockers, so it's a soft cap on service for governments. They won't talk about it, but that's the way they think of it. And it's worth about $10 billion a year in Canada right now. And it's really playing havoc with the cutting specialties throughout Canada who can't get beds to do the work. So I think there's a reason to expect that we should be restructuring healthcare, transformative change, and thank you very much, and I'll take questions if you can, and I appreciate your patience.
Thanks very much, Dr. Furlong, for your very comprehensive and view of both the history of what's happened in healthcare, but also your perspectives on what could change to improve healthcare.
Well, I thank you very much for the opportunity to be here, and for all of you to be here and partake. And we have challenges, and we need to fix them. And why do we need to fix them? We need to fix them because our great-grandchildren would expect nothing less of us, and their great-grandchildren would expect nothing less of us, I think, Doctor.
So open for questions? Karen?
Comment and then question. I mean, I perfectly agree with you in your statement about politicians. I remember my grandfather used to say, a politician only thinks about the next election, while a statesman, like Tommy Douglas, thinks about the next generation. And I think that's perfectly reasonable, and that's what we need at the moment. Somebody who ignores politics and thinks about the next generation.
Absolutely.
And my question is, part of that is that when you said the federal government is getting out of healthcare, and you some aspersion on the federal government, but isn't it a two-way street? And I'll be devil's advocate here. Is that the provincial governments with wildly different needs and wants have constitutionally said, shut up and sign the check and don't tell us how to run healthcare. And we really have to sit down and have it more national, or we lose universality and accessibility even more so than now.
Well, the Canada Health Act is dysfunctional, that's the first thing, and the federal government, who started at 50%, during this period of baby boomers, the projections are that they could be below 10% participation. That's going to be deadly for the provinces that have lots of old people, Newfoundland, New Brunswick, Atlantic Canada. And there's a book written by Richard Sion called the School for Public Policy in Moncton, called A Tale of Two Countries, where he compares Atlantic Canada to the rest of Canada. As we speak today, the government of Canada is adding to Canada a Newfoundland about every 16 or 18 months. and they're adding to Canada New Brunswick about every 22 months. We're becoming less effective politically. We have less import because we are now 30 full seats in Atlantic Canada out of 330, and it's very difficult to make any noise. But I do firmly believe that the federal government coming down, drawing the line in the sand on the healthcare accord, and getting rid of the Health Council of Canada, and basically showing no leadership interest, continuously now putting in the health portfolio in Ottawa low-key ministers, where they were always high-profile ministers, and now they're not. So I can't see them returning to taking a leadership role right now. So I agree with you. It's unfortunate, but the reality is, what happens to a province like New Brunswick when we get to that hockey stick curve? And what happens when New York says, sorry, we're not giving you any money? We all saw what happened in Detroit. Will the government of Canada bail out New Brunswick? I don't think they will. They may do something, but they certainly won't bail it out if we're functionally bankrupt. Because they may have to do the same for Quebec or Ontario sometime, and they want to set a precedent, of course. So what do we do with healthcare? Healthcare is provincial because of the BNA Act, and when we divided up the spoils, the federal government took the things that made money, like natural resources and offshore and all that, and the military, and they gave to the provinces and the two territories at that time the things that didn't make money, education and health. It's all yours, guys. But when health got very, very, very important, the feds wanted in. They wanted to get some bang, political bang for the bucks that they were putting into healthcare across the country, and they couldn't get it. The provinces were getting it. So they're, I think, backing away. And I think the other factor they were backing away is they know full well what's coming on that hockey curve in the next 20 to 25 years. Now the provinces are going to have to deal with that, and I'm not sure they can.
Question? Yeah. Hi, this is a completely outsider question, so it might be ridiculous, but and it probably won't relate to baby boomers, but I didn't hear you mention prevention. Is that because, I mean, I'm French, so culturally, one thing that I find surprising is the quality of food. That people are, a lot of people are putting in their bodies, which contributes to, seeing people seem quite ill and more so than I'm used to. So that obviously can't be helping the whole thing. Now, it might be a drop in the ocean in comparison with everything else you've been saying, but.
Well, wellness, categorically, is not the absence of illness. And our illness care system is what we have right here. We take care of illness. There are some wellness things in there, immunization, baby care, and there's some things with, clean water and safe food and so on and so forth. But it's still an illness care system, and when you try to make it into a wellness system, it's like taking a tractor to a Formula One race. It doesn't fit, it doesn't work. And doctors are not into the wellness equation. They're into the wellness, absence of illness equation. But when you look at things such as 1 in 5 of Canadians being overweight, and 1 in 3 being obese, we look at the trend of people now who come into practices that I've just done. People want to be in great shape the day they die, and they're expecting the health system to do that. But they're not interested too much in issues related to lifestyle. Okay, and we have missed the boat somehow on that, and I think it's because we've taken too much money out of education where all that should happen. Lifestyle issues got to be taught in school, start in grade 1 or kindergarten, and we can't expect the health system to teach lifestyle stuff. There's not the time, and first of all, in health care, We don't see everybody. In the education system, they do see everybody. So if we want to do something about wellness, it has to happen in the education system. I've been adamant about that. I tried to do that in the short time I had in government. I got some stuff done, but it's hard to make change. And sometimes somebody arrives and just does away with it. But you're quite right. The more we can pay attention to lifestyle, the better it'll be for everybody.
Other questions or comments?
Would you comment on what seems to be a serious deterioration in rural healthcare?
Yes, I can. And rural healthcare will always be a problem in a big country like Canada, and increasing consolidation of medicine to bigger centers because of the complexity of what we have to do. And not only the complexity of what we have to do, but the demand by every patient everywhere to have that complexity. So big centers will have the complexity. In rural areas, here are the numbers generally. And again, I'm a soft number guy, but I have a fair idea. In Canada, 20% of the population lives in along the 49th parallel there in the lower part of Canada. About 80% live in what we call urban Canada. 80%, and the definition of an urban situation, I believe, is 10,000 people. So we have 90% of our doctors who live in those areas, okay? So the urban areas have about 10% of the doctors in Canada and about 3% of the specialists, and what we call define as rural. So there are challenges to keep and give health care, and we have to have life-sustaining care in rural areas. You have to be able to do surgery, you have to be able to do anesthesia to save a life, but you're probably not going to get coronary bypass, as you're well aware, or you have transport, but the transport systems that we have now to help rural health in Canada are immensely better than when I started. So we're always going to have the issue, but the issue is how do we get people out there? This university here has been excellent in training people for rural healthcare. This one and a couple of others in Canada. And Memorial has led the parade generally in training people who can work in a rural area. But again, the people who deliver healthcare in rural Canada consider themselves quite different than the average doctors in Canada. So different that they have their own association, the National Association of Rural Doctors, okay? They have their annual meeting, they have a journal that comes out, I think, quarterly, and they have the whole slate, and I don't think the Canadian Medical Association quite appreciates it, but it's there. And it's a message to urban Canada that, look, we got different problems out in rural Canada, and we need them addressed. So yes, it's an issue. I think people are trying, but it's very hard to convince people to go to remote rural areas. So yes, we have an issue, and I think most governments are doing their best to get around it.
Yeah. I understand what you said about wellness, but don't you think, and I think you do actually, that if we had more of a sense of our whole healthcare system, or even just look at a provincial level, based on the whole primary healthcare model with community centers that are more involved with the lives of the people who are coming to them, not just in and out, that we actually do have education going on and preventive programs going on through healthcare centers, that we will, down the road, see less money going into acute care in terms of control of disease, etc.
You're right. I think there's no question that basically the theory that you're saying there is correct. The way we're operating now in an illness care system doesn't translate, as I said, and it has to fall into the education system. But primary care today, I think, is the biggest challenge in Canadian healthcare system. Okay, just to make it clear that I'm a primary care deliverer. I have been all my life, and I have the greatest respect for my colleagues because they're all very, very capable, knowledgeable, and go work anywhere in the world. But what we're doing right now, for some reason, primary care in urban areas now, not so much in rural areas, but in urban areas, primary care delivery is about 35 or 40 hours a week, and it's all the same 35 or 40 hours, 9 to 5, 4 or 5 days a week. So that is what's playing havoc with our emergency rooms. We've kind of abrogated in a way because we put in place walk-in clinics, after-hour clinics, which is what I call McDonald's medicine, and that's what's happening now. We need reform and some sort of change in how we do primary care. And as long as it continues like it continues, then we're going to have the carnage that we have in our emergency rooms, where 80% of people in emergency rooms by studies are primary care. And these people in emergency rooms are trained for high intensity, low volume work. And what do they have on Friday night and Saturday and Sunday? They have high volume, low intensity work. And in order to stay safe, they do lots of testing, x-rays and consultation, because they have to run fast. And they also have to take care of the truly ill people and injured people and sick people in the emerge. So that dynamic between primary care and emergency room needs to be resolved.
Part of the transformation, I think, that needs to happen.
And it's the same right across the country. And it's not so much in rural areas. And basically, if you look at Canada and healthcare, pretty much all of Atlantic Canada is rural. In context, in healthcare delivery, we still have lots of physicians who are primary care, who work in emergencies and do deliveries and work in hospitals, in concentrated care units, and so on and so forth. But in large centers, most of the primary care people rarely go to a hospital. That's the way we're operating.
Do you have any concept or any ideas around the use of wait times to really predict your demand? Do some work around wait times. What we're recognizing is that really the wait time or the individual on the wait list is probably only about at best 50% accurate. So that's not a true reflection of demand. If you take that list in one time and ask all 100 people, do you want to come and see us? Likely 50 will say, because they've been there so long, that their issue, whatever that is that they require at that time, is gone. They sought service somewhere else. If they no longer require it,
Well, wait times are tremendously challenging because there's no one answer to it, and it's a product of the whole system, both the consumers who are very demanding today, as I said, and it's not unusual in a primary care to have someone come in and say, well, my neighbor is 50 years old, he had his checkup last month and he was fine, and now he's in hospital with cancer. I want everything done. The pan-man scan, I want everything done, every test, and so on and so forth. And you can either spend half an hour talking them out of it, or 2 minutes filling out the forms. So how does that work? So they go on a list for lab. They come in. I mean, it's the amount of overutilization, misutilization is high. And I can tell you, because I started in the 70s and finished in just 2 years ago, and not unusual to see someone with a small little thing on their hand and say, Doc, this there, and how long's been there? A year? I want to see a dermatologist. Okay, it's not serious, it's not a problem, you're not a cancer, you can talk to them all you want, but still want to see a dermatologist. I said, well, I can make you an appointment, it'll probably take about a year, year and a half, if you want to wait. And the demand for specialty care in primary care is astounding. And there was a time when we tried to talk them out of it. We didn't need it, but it's hard to do it now. And a lot of times people will just go to another physician. Polydoctoring is common. Over-investigation is common. But inevitably, we have, I think, a 20% useless utilization factor. And again, that's $45 billion a year in Canada, $500 million here, right here, if you extrapolate to Newfoundland. That has to be attended to. The only way you can do it, I think, is prorated patient participation and initiative on the demand side.
There's a Swedish, I don't know if you know the Swedish, I don't know if they're still doing it, but they had this triage system by phone. And apparently it works So they had obviously trained staff on the phone who would go through and determine whether or not. And as I say, I heard about that like many years ago. I have no idea if it's still happening, but apparently at the time it was working.
Effectively, it would be a demand-side control. The way you're explaining it to me, I'm not familiar with it, but that is a demand-side control that you talk to somebody and keep them from entering the system. But if you're in a primary care office and the patient walks in, sits in your room, when you go in there, they're already in the system.
Oh yeah, of course.
And you have no idea what they're there for because you can't predict. They may say to the secretary, I'm here for my annual checkup or something, and when they really want to talk about some other major issue, that is it. So it's very difficult. It has to be the consumer that decides that they don't need the care.
Yeah.
And they have to have that incentive. And that incentive can only be participation. That's not ominous, but it's there. And someone like me, with what I do, maybe my prorated participation for a year would be $1,000. So if I go in with I'm touching my chest, the first $1,000 on a $300,000 cardiac event, I pay, and the system pays the rest. So it's not ominous, it's not preventative, but it may start people thinking the first time about cost. Because nobody thinks about cost now. And the first initiative I've seen is Choosing Wisely that came from the Canadian Medical Association a few years ago. I appreciate your attentiveness, and thank you for being here. And again, it's a pleasure for me to be here. Nostalgia is here, and I have great respect for Memorial Medical School, who's made a history and a position of excellence in Canadian healthcare training, and I'm serious about that. It is an excellent school.
Well, thank you very much, Dr. Furlong, both for your excellent talk, but also for your kind words about our school, of which we're very proud. And this is just a small token, and obviously with all the people here and all the questions, we were very interested in what you had to say, so thank you very much.
One more word. I left a batch of books over there. If anybody wants some, you can have them. And thank you,
Yes.
Dr. for
Thanks very much.